My name is Jason Sicklick. I'm a surgical oncologist from California, from the University of California, San Diego. I have a basic science lab as well as a clinical practice focused on treating patients, both adults and adolescent young adults with GIST. In addition to myself moderating the session, we have 4 other distinguished individuals on this panel. So the first one is Dr. Ricardo Gonzalez from Moffit Cancer Center here in Florida. Dr. Subhawong from the University of Miami Sylvester Comprehensive Cancer Center. Dr. Breelyn Wilky from Miami as well, University of Miami. And Dr. Markku Miettinen from the National Institutes of Health. So the way we plan on doing this session is we've got some questions that I'll go through, and then we've also we'll have the microphone going around if any individuals want to ask other additional questions of it. But to start off, I'm going to start off with a very broad question, and this is something really for the entire panel. And so the first question is do you need to see a GIST specialist, whether that be a medical oncologist, a gastroenterologist, a surgeon, pathologist? What's the role of a multidisciplinary team? What questions do you need to ask these individuals if you're seeing somebody? Minimum numbers of cases or patients that they see in a year. And so I'll start off by opening this up to the panel. Sure.
So thanks for the privilege of being here and for organizing this. So the question is whether or not you should see a GIST specialist. I think everyone in this audience acknowledges very clearly that the answer to that question is yes. But more so is why. Obviously you can go through how patients with this disease present, that it's a rare disease. It's caught incidentally in a lot of folks, but then, the decision to have proper management by a team as orchestrated with the patient should come from a group of folks who see this regularly, because you oftentimes only really get one shot to do it right. With a rare disease like this, the centers, groups who have pathologists who focus on the diagnostics, who have surgeons who focus on the technical aspects of the resection, when to do it when the disease becomes advanced or metastatic, becomes even more esoteric, and medical oncologists who focus on the decision making of what drugs to start and when, what clinical trials are available, and frankly, whether or not there's a tissue repository to learn and study the disease for future patients, I think forms the basis for why you should be seeing not only just a GIST specialist, but going to a program that focuses on sarcoma and gastrointestinal stromal tumors.
So I agree, and I'll just add a couple of things. So it doesn't mean that you necessarily have to be treated forever at that center. You don't have to make a trek 5-6 hours away from your house to, and have to go there for every single follow-up visit, every single scan. But even just having that initial look over with the team. We use tumor boards a lot, where you don't even necessarily have to see 5 or 6 different doctors, but you get 5 or 6 different doctors' input. That can really give you peace of mind, and just be able to set up a network or contacts in case you need us down the road.
Just echoing those comments, I think it's important for me to point out also that just because you're going to a center where physicians aren't seeing a lot of just patients, they're not smart, it's just that they're not seeing the volume that would make them comfortable with the latest updates, treatments that are available. So they may know just, they may know associated feedback treatment, but they don't know about all the different patient estimates available, different settings, different therapies available.
This is a question for Dr. Gonzalez. So you alluded to this earlier, and the complexity of decision making for operations. So how do you decide who should get an operation and who shouldn't, and how you should approach it, whether it's laparoscopic or open, or whether the gastroenterologist should think about doing this endoscopically? So, good question. Throw that at you.
So, thanks for that. Those are great questions to talk to, actually. So I'm going to go through. I'm going to briefly summarize how patients present and when it may be considered to consider an operation first, or to have some form of treatment first and then consider surgery thereafter. So in general, patients will present incidentally for another reason. A lot of times folks will have a small lesion or even a fairly large lesion identified in the stomach or lower down because of imaging for another cause, whether it's abdominal pain, dyspepsia, kidney stones. Who knows? A lot of times folks will have a small lesion or a bigger lesion picked up by imaging. If it's a tiny lesion, say less than 2 centimeters, that shows up in the stomach, I can't agree more with Dr. Miettinen that lesion should be observed, and that's the standard approach for folks with tiny lesions, if they're asymptomatic, of course. Now, there are some that are on the cusp, 2 centimeters to maybe the upper limit of comfort level of the surgeon to consider operating on the patient laparoscopically to avoid the risk of tumor rupture during surgery. For folks with that kind of cancer presentation, one can consider, if it's a smaller lesion, a laparoscopic or a robotic approach for resection, but fundamentally, the principles of oncologic surgery are critical. The patient must have an operation with the intent of rendering the patient without evidence of disease at the conclusion of surgery and without disruption of the tumor having been removed, if laparoscopically through a protective bag from a port, or if open, certainly, without disruption of the lesion. As these lesions get larger or become symptomatic, certainly larger, the tumor could be considered at higher risk, greater than 8-10 centimeters, for example. For folks who have that kind of presentation, I would consider that a locally advanced tumor. That's when I would, certainly as with every patient, discuss with my medical oncologist in clinic. We have a multidisciplinary clinic at our center where we have surgical oncologists, medical oncologists, radiation oncologists that consult 4 patients at the same time if necessary, and consider starting neoadjuvant treatment. So that would be treatment with the intent of going to surgery at some point once we see a response in the disease after a period of time for which the patient has received therapy. In those folks, what we would tend to do is consider operating on the disease after a response has been noted, and we usually see a response 65-70% of the time, with the intent of making the operation simpler. Now, there are some theoretic benefits to this as well, that the tumor becomes less fragile, theoretically, certainly becomes smaller, and the goal is to make it a simpler operation so that you reduce the risks of surgery. The same principles of surgery apply. There are times when we can take a larger lesion that's maybe 5-10 centimeters, and with treatment get it to a smaller lesion that can subsequently be resected laparoscopically. I'd say that our success rate with converting an otherwise potentially multi-visceral surgery, which means surgery with removing the tumor plus anything that it could be touching, turning into a laparoscopic procedure, probably range around 15 to 20%. Usually if it's considered open at the beginning based on assessment from the surgeon, about 15-20% of the time we can successfully remove that laparoscopically after neoadjuvant therapy for a fairly large lesion, but certainly not all the time. In the setting of recurrent disease or metastatic disease, the decision to operate becomes a little bit more complex because you have such good drugs to try to treat the tumor. If the disease is stable on treatment, Chan Rao, DiMatteo, and others have demonstrated in retrospective studies that patients can go to surgery if the disease is either stable or responding, and there's no evidence of multifocal progression on treatment, and if you can render the patient without evidence of disease at the conclusion of the surgery. Now, whether or not today, the question that one could ask is, is there a definitive benefit to operating on somebody, for example, after they've had progression on first-line therapy for metastatic disease versus somebody who's had second-line therapy with sunitinib? And that question is going to be difficult to answer because I think there's failed randomized trials to try to answer that question up to now. One from Asia and one from the European nation. So we in our institution tend to give folks the benefit of the doubt, understanding that progression-free survival, meaning how long you live without change or a sign of change of growth of cancer in another area, is at least likely as good, maybe better than second-line therapy after the disease has progressed on imatinib. So that probably captures.
I think that captures. I'll add a follow-up question to that. So if somebody's disease is progressing on, let's say, sunitinib or third-line regorafenib, should they get an operation at that point?
Right, that's a great question. So there's no real short answer to that. It has to be taken on an individual basis. If the disease can be rendered, if the patient can be rendered without evidence of disease after sunitinib or regorafenib, I think that individual deserves a chance. Now, in the counseling and discussion that I share with folks in that setting, the three drugs are different, and where a surgical oncologist is important is understanding that those three drugs are different. They're different in terms of wound healing. Patients who are on the second and third line drugs may not have as long as a progression-free survival compared to patients who are on the first line drug. The wound healing is different in terms of the complication rates. So one could view somebody who has had cancer that's progressed after first line with a potentially resectable paradigm with manageable risk a little differently than after second and third line because of the potential wound healing problems that can develop after sunitinib or regorafenib. So you have to give a little time for the drugs to wash out. If there's been nice response and the disease can be removed and the operation isn't so overwhelmingly complex that the risks are overwhelming, then there is an option to consider surgery in that setting.
Okay. Going back to the preoperative imatinib or neoadjuvant for the terminology we use. Do we need to check mutation status before putting somebody on imatinib? Or if somebody comes in and is referred in clinic, should we just put them on imatinib if our goal is to shrink the tumor down for an operation?
Sure. So just to remind everybody, you probably heard Dr. Trent talk earlier, but when we talk about GIST, there are certain genes that have a mistake that cause the growth of these tumors. And you guys probably all know that in the majority of these patients, the mistake is in KIT, right? Now, we talk about where in the KIT gene that the mistake occurs, kind of like mile markers. So about 80% of patients will have their mistake in mile marker 11 or exon 11, and those are the tumors that respond the best to Gleevec. There's another 10% that might have mile marker 9 or exon 9 mutations, which often need a higher dose of Gleevec to be effective. And then there's a mixed bag. I think Dr. Trent showed this slide earlier. Even genes that have nothing to do with KIT can be mutated, and the potential is that if you just randomly give imatinib to those patients, they may not have your expected benefit, and it could delay time to surgery, even lead to progression or making a surgery impossible. So whether or not you have to wait is an individual decision, like most of these things. For somebody that's got a pretty straightforward GIST, so it's in the stomach, it's pretty big, we know that we can make surgery a little bit easier if we can shrink it, and there's not any weird things, meaning the way it looks on imaging or particular history, I would say that you can probably go ahead and start the Gleevec. Sometimes we don't have enough tissue to do the mutation testing, especially if it was a very tiny biopsy. And with close monitoring, usually you've got an 80% chance, or even partially with the exon 9s, of being able to wait to get that testing. You don't usually burn any bridges with Gleevec. Now, the other thing is that it takes time to get the drugs, and so often with modern mutation testing, the timelines kind of fall together. So you can go ahead and order Gleevec, and then hopefully you'll have mutation testing back, so you can change the plan if it turns out that you've got one of these weird things. But in general, I usually don't hold back because I don't want to lose that time just playing the numbers. But it's always in a perfect world, it'd be great to have that before you make a decision to start.
How mutation testing typically take?
So if your institution does it in-house, we can get the most common, what we call the hotspot mutation testing, even within a week or two. It's very fast. Now, if it comes back negative and you're not picking up your most common KIT and PDGF mutations, what we usually will do is send it out for what's called whole genome testing, which is a much bigger panel of genes to look at to try to pick up those oddball mutations that we looked at earlier. So that can sometimes take, in the best case, 2 to 3 weeks, sometimes longer if there's issues with the sample, if there's not enough DNA, et cetera. So it's variable.
Okay. Sort of along those same lines, Dr. Miettinen, if the mutation testing comes back as negative for KIT and PDGFR alpha, what should the patients be thinking about? What should the doctors be thinking about in terms of sort of next steps and workup?
First thing, you should look which mutations of KIT and PDGFR alpha were assessed, because it's possible that not all the relevant hotspots exons were assessed, and if not, then perform more comprehensive KIT and PDGFR alpha mutation analysis and actually next generation sequencing systems automatically do that all in many cases, and we have had patients that have been considered KIT wild type. However, in the clinic it was discovered that after all there is other less usual KIT mutation, and that's very valuable information. Then number 2, after if now it is wild type, in the comprehensive analysis of KIT and PDGFR alpha, next thing, unless it's already done, SDHB immunohistochemistry, which will cover all SDH complex aberrations, whichever there is, and that is the most common wild type group. If you take collectively all SDH aberrations, and it's a simple test and it is fairly inexpensive, let's say less than $100 for the immunohistochemistry for SDHB specifically. You can even do SDHA on the side, because then you can already say there is an SDHA mutation if there is a loss of SDHA. So we assess losses of SDHB and A by immunohistochemistry. Number 3 would be neurofibromatosis, and now it would be neurofibromatosis 1 syndrome that produces GISTs, or it could be somatic neurofibromatosis 1 gene loss of function mutation that causes a GIST also. And luckily, in many cases, these are indolent GISTs, but not always, and it certainly can help the therapy if this mutation is detected. And then BRAF mutation, which is already in all next generation panels automatically, because it's one of the more common cancer mutations. It's rare in GIST, but less than 1% perhaps. Then important, although very rare, NTRK fusions. Very rare in GISTs, but the significance is that there is an in vitro therapy for them available, which could be really make a big difference for that one patient. And this NTRK fusion can be done with the fusion cell system or comprehensive RNA sequencing, plus these days also very powerful and good immunohistochemical screening for NTRK with antibodies, just like SDH testing. It's now becoming available.
Can you explain what a fusion is?
So gene fusion means that in this case that there is NTRK is like hip type of kinase. It's a receptor tyrosine kinase, and it is driven by a very actively propagating gene. For example, tropomyosin gene, and it's making NTRK receptor as an oncogene. So two genes together, which is an abnormal configuration. Normally they are not playing together, but here one gene is driving this oncogenic NTRK in a NTRK fusion gene.
Okay. I'll just add to that. There are some other rare fusions events that also occur in GIST. There's been reported KIT, PDGFR alpha fusions from the NIH group. We just reported a BRAF fusion a few months ago. And then there's also FGFR1 fusions that we identified in collaboration with Foundation Medicine. So I think we're starting to learn more and more that these fusions are a rare subtype, but they're an evolving subtype that we need to be cognizant of, and that's where sort of some of these next generation sequencing panels can pick up these fusions that the single hotspots might not pick up in the situations when KIT or PDGFR alpha is negative. We've been neglecting Dr. Subhawong, so I'm going to pull you into this. So what's the difference between a PET scan, a CT scan, an MRI, and when do we use what with all these different modalities that we have to offer patients?
So that's a great question, and I'll start off with addressing what CT scans are, because I think these are the workhorse imaging modality for GIST. So CT scans, also called CAT scans, basically they are giant X-ray machines, and the X-rays are shot at 360 degrees around the patient's body, and then the computer goes back and reconstructs internal tissue densities of the organs. Inherently, it's a structural imaging modality. So what we're looking at there is often lesion size, where the lesions are located in the body, what organs are involved. The other modalities are often used as more of for MRI, for example, more of a problem-solving modality. So MRI doesn't use ionized radiation, but it takes a lot longer for the images to be acquired. So many of you have had MRI scans, you have to lay inside the board magnet for a long time. It can be very claustrophobic inducing. But it has some advantages in depicting pathology in organs such as the liver and the brain. So we use it when we're unsure about spots that may show up on a CT scan. We're unsure what the nature of those lesions are. Sometimes there are other entities and lesions that appear in the liver that can mimic GIST metastases that we may want to evaluate with MRI scan to see if they're actually metastases or other benign tumors. For PET scans, we often use those also as a problem-solving modality to assess whether the tumor is alive or dead. So the PET scan is looking at metabolic activity, and in tumors that are alive and actively dividing, they'll show up as hotspots in a PET scan. When the tumors are being killed by the drugs, then the PET activity decreases. So we look at a decrease in PET activity to indicate successful treatment.
So is a PET scan necessary every time you start somebody on treatment, and then you want to go back and check and see if it's actually working?
So in a lot of the trials, PET scans are used early on to try to predict whether the treatment is working. So some clinical trials are designed so that the patient gets a PET scan within the first week to 4 weeks after initiating therapy, and it can give kind of an early response assessment. But subsequently, there are CT criteria that have been developed to assess response to tumors based on contrast enhancement. So that's why it's important when you get a CT scan that they give contrast, intravenous contrast, because tumors that are alive will take up the contrast, and tumors that are not won't take up the contrast. So they'll look differently on the CT scan. But it's not necessary to get a PET scan on multiple subsequent visits. Usually we use that more as an early feature response or in problem-solving cases. But CT, contrast against CT, in general works for the most part on those subsequent follow-up.
Okay. Sometimes, get a question?
I'll follow up on that. How often, typically, do you get PET scans if things are, quote, stable after a couple of years?
If everything looks stable on the CT scan, I would say there's probably a very low yield to getting a PET CT. And I'll just add as an aside, the CT component of a PET CT is usually not really great diagnostic quality. The CT is being acquired as part of the PET scan just to help the radiologist kind of localize where the hotspots are anatomically, because PET alone does not have great spatial resolution. So the CT component of that exam is just kind of a poor quality CT scan to localize a little bit better where the lesions may be playing out. I don't know if we're going to talk about the need for a PET scan in that situation where you had stable disease. You really don't do that.
Yeah, basically, I use the PET scan for problem solving. So sometimes we'll get a spot on a CAT scan that either wasn't there before, or we're not really sure if it's a dead tumor or a living tumor, and after discussion, we'll sometimes get a PET to kind of help clarify that. But remember, PETs are 20 times the radiation and probably about 20 times the cost too. So most of the time, your insurance company is going to throw a fit. So we have to make sure.
What are the complications? My wife's had 50 over the years. That seems like an awful lot of PET scans.
Some people you have to. That's the other piece, is that IV contrast with CAT scans is bad for your kidneys. So we've got a handful of patients where we really can't use IV contrast. And so for those patients, I do use PET scans. But we try to avoid it when we can.
So another radiology question. Oh, go ahead.
In terms of radiation risk, yes. So as Bree was pointing out, PET scans have a much higher radiation dose than CT scans. I will say that a lot of the data that we use, right. So with MRI doesn't use ionized radiation, so there's no, we don't believe there's any cancer risk to MRI scans. A lot of the data that drives the discussion on radiation risk and CAT scan is actually extrapolated from use of the atomic bomb and exposure of large populations to large amounts of radiation. We don't have a lot of good data on exposure of relatively small amounts of radiation. So a CT scan may be a few times your annual exposure to the natural background radiation that everyone gets. So it's somewhat of an exercise where you're taking the best data that you have, but a lot of it's older and it may not extrapolate very well to these low doses of radiation that we have for diagnostic CTs. But there's no safe level of radiation.
When we hold off on questions, I promise you'll have ample opportunity to ask you questions with the panel. Julie, you'll be first.
I'll just ask sort of an additional question to that, and you might not know the answer, is what's the equivalent radiation exposure in a CT scan versus what you get flying across the country in an airplane?
That's a great question. So I don't know the exact number of millisieverts of exposure. The natural background radiation is around 3 millisieverts, and a CT scan exposure depends on the body part being imaged. So if it's a relatively, if the tissue that's being imaged is relatively insensitive to the radiation effect, so an extremity, you get a very low exposure risk because extremity tissues aren't very sensitive to radiation. They're not going to go on to develop sarcoma. But for body, chest, and abdomen imaging, the dose is around 5 millisieverts. So in my mind, I equate it to about 1 year of annual background radiation, 1 to 2 years. In most cases, it varies between scanners and between patients. That's a rough approximation. In terms of flying across the country, you get more exposure because as you gain altitude, you actually increase your exposure to the radiation. So people living at high altitudes, like in Colorado, actually have a higher radiation exposure than people who live at sea level. But it's a relatively trivial amount of radiation.
Or people flying across the country all the time.
Right.
Along the lines of one last question in terms of radiology. So you get a CAT scan and the tumor is responding to therapy, but now it's 3 centimeters bigger than what it was when you started. Is the drug working? Is it not working? How do you know?
Another great question. So when the CAT scan shows an increase in tumor size, in this tumor type, if you've been on therapy, the first question that should be asked is this real progression disease or is it pseudo-progression? Because the tumors that enlarge in size may be enlarging because they're actually dying. So they undergo internal hemorrhage or myxoid change, and they will increase in size. But that's why it's important to have the contrast, the intravenous contrast on board, because they may decrease in terms of their enhancement. So the tumors won't take up the contrast as much, and that shows up as a decrease in density on the CAT scans. So there are criteria that have been developed to create thresholds for when we call something progressive disease, based not only on the size of the tumor, but also on that contrast enhancement. And that's a really important component. And I don't know if
I was going to ask you, actually.
Can I piggyback on top
Sure,
of that?
absolutely.
So that speaks to, what you just shared, speaks to the importance of, at least every so often, if you're having care that's separate from a large center, going to the referral center if there's a change, to see if it's actually really a change versus something that's could be positive, like response. You see these CT scans every day, every single day. Whereas in other areas or other parts of the state or the country, another radiologist may see a CAT scan or some form of cross-sectional imaging for a sarcoma or a gastrointestinal stromal tumor, once a year. So that speaks to the importance of this.
The question I was going to ask you is, how does a tumor becoming sort of necrotic or dead or growing, pseudo-progressing, how does it change how you think about doing an operation?
Over time, I tend to see the myxoid degeneration that you're discussing tend to consolidate down a bit. So I'll let folks who are on treatment before surgery, if the disease is getting smaller with every CAT scan, or even it gets bigger at first, as long as it's responding with every CAT scan, go until I see 2 CTs over a 3-month interval side by side that look basically the same, meaning that the plateau, the response is over the plateau. Now, if at that time it still looks like it's a large lesion with a lot of necrosis, then manipulation of the disease during surgery is minimized, and frankly we tend to manipulate everything around it rather than touching the tumor. Protect the area around it during surgery such that if something were to occur, we would minimize spillage. But yeah, it's definitely something to think about. I'm sure you share the same thoughts when you go to the
Absolutely. Dr. Wilky, sometimes patients are on 400 milligrams of imatinib and they're having toxicities, and sometimes on the lister we'll talk about dropping their doses down to 300, 200, imatinib level, checking. What's the role of all this, and when should your physician be thinking about doing that?
So that's a great question. So again, I think you'll get different answers depending on who you ask, but at the end of the day, the trials that were very large and showed these conclusive benefits did not use drug levels of imatinib. So they showed that imatinib 400 milligrams could produce improvement in recurrence-free survival. It's an overall survival for GIST tumors. So when you start to tweak that and you start to cut down, you get into this area where we don't really have all the information that we need to give you adequate consent about what your risks are, what we could potentially be happening. So it's a judgment call. So I'll give you a couple examples of people where I have dropped the dose down and we continue to have good outcomes. So I have a guy that's got bad diabetes, bad hypertension, and this will actually have another question. He had a terrible GIST, high risk, was resected in an unplanned fashion. I think he had bad exon 11 mutation with a deletion, and it was 15 centimeters in a small bowel. So every bad risk feature that you could have, this guy has a very high chance of recurrence. Put him on imatinib 400, and his creatinine went from 1.3, that's your kidney function, 1.3 to over 2 in a couple of months. We talk about kidney problems late after being on Gleevec for years, but this guy immediately started to have kidney problems. So the question is, okay, I might do more harm than good at that point, right? And so for him, the balance was clearly I was doing more harm because his kidneys were shutting down and he was at risk for having to go on dialysis. Now, for most patients, it's not going to be that clear cut. There's not going to be a clear example. And so if it's a side effect problem, we have a lot of good medicines to manage side effects. And so what I tell patients is whatever possible, let's exhaust all our supportive care before we start cutting doses down. As far as the dose levels or the imatinib levels, so I think we haven't conclusively shown that that can replace the dosing that we know in the trials. I think nowadays with the generics as well as with the recognition that some medications can interact, if you have a patient where you're not sure what's going on, so let's say you've got somebody who's having these horrible side effects and it's sort of out of proportion to what we would expect, that might be somebody I would check a dose level on because maybe they're one of these hypermetabolizers. So meaning some patients just break down drugs very efficiently and you've got a much higher level of Gleevec in their system than you would anticipate from the average person. So overall, in a nutshell, I don't use it very often, but I try to, whenever possible, keep folks on the recommended therapies to avoid confusion and inadvertent outcomes, problems.
Playing off one of the things you mentioned, generic versus brand name.
I knew you were going there.
You open yourself up.
All right. I hate this question. I really do. And the answer is that it literally makes me just want to sit there and tear my hair out every single time because we don't know and we're sort of pigeonholed into this situation. So in a nutshell, all the trials, again, were done on brand name Gleevec from Novartis in the drug studies. And then now you've got generic companies that are supposedly producing drugs that have the bioequivalent, meaning that the active ingredient is supposed to be the same and the amount of metabolism is supposed to be the same, but everything else in that drug could be different. So the fillers, all the things that that can affect side effects, that can affect how you live your life could be completely different. And there's that minor detail that they don't require generic companies to repeat the same big, well-controlled studies that showed benefit in the first place. So the short answer is that we try to keep folks, particularly those who are at high risk or already have metastatic disease, I try very hard to keep them on brand names so that we don't rock the boat. For patients on adjuvant treatment where the insurance company is pushing for generics, we have a conversation about it. And I've had people have their side effects change when the insurance changed one generic to another generic. So in all those cases, if there's any doubt, I'm very quick to write dispenses written and to try to get the brand name, especially since the cost savings is really not that much right now because there's not that many competitors out there. Yes, I'm not a fan, a little bit.
I have one more follow-up to that. When do we expect the clinical trial of the brand name versus the generic?
I don't think it'll ever be done. I don't think anybody's ever going to do that. And there's a variety of reasons why that is. It's expensive. You would have to have a huge number of patients in order to prove changes in outcomes unless it was floridly different. And frankly, the drug companies probably don't want that to ever happen. So it's going to be one of those questions. But organizations like the LifeRaft group are collecting data as best we can for patients that do elect to go on generics. There's an ongoing initiative to try to gather that data so that hopefully we can learn something, even if it's not in the same controlled trial fashion, and at least we'll have some experience as time goes by for others.
That was the answer I was expecting. I just wanted to put it out there. So another follow-up question for you. So I've had my GIST taken out, no tumor spillage. When do I need to think about getting imatinib in the postoperative setting or adjuvant setting?
So we have risk stratification criteria from folks sitting at this very table, and it's really an honor to be sitting here. But basically, we've established for GIST that there are 3 or 4 main factors that contribute to recurrence risk after surgery. So size, the location of the tumor, so where in the gastrointestinal tract it's occurring, and then the mitotic rate, which is the number of cell divisions that you see in a particular area. And so this also is a factor that's important to think about when you're making a decision decision about whether you're going to commit to Gleevec or not is, has your GIST been counted by an expert pathologist? Because many times in the community, they're not going to count the 50 high-power fields, which is a lot of work, and you hunt for these little teeny growth figures. And so that's a really important factor that is probably the most strong predictor of whether somebody's GIST is going to come back or not. So little things like that can make a difference. But basically, if you are low risk, your chance of your GIST coming back is probably less than 5%. We do not use Gleevec for low risk GIST, which are small, in the stomach, and low mitotic rate. On the other extreme, if you've got a big GIST, one that's in an intestine or another weird location with a high mitotic rate, then your risk can be almost 100%. And so for those patients for high risk and intermediate risk, the data is pretty convincing that you must do adjuvant Gleevec or risk recurrence within a short period of time. How long? This is continuing to be explored. So we started with 1 year, and 1 year was better than nothing. Then we went to 3 years. 3 years was better than 1 year. The 5-year data is going on now, and you can still see that when people come off the studies, within about 6 months, there's a fraction of people that it's going to come back. And so this keeps getting explored and explored. And so although we don't have the final data for my super high-risk patients, we leave them on. And I have a patient that lost her insurance. I didn't know about it. She stopped her Gleevec, and within 6 to 8 months, which she missed her appointment, bad. But anyways, she had recurrence that fast, and she's been on now for 4.5 years. So these are the sort of things that we're seeing, and it's a discussion obviously for every patient, but I'm quick to keep Gleevec on board.
So along those same lines, 15 centimeter tumor, the surgeon takes it out, they send it off to pathology. It's got a high mitotic index, and then it gets sent for sequencing, and it comes back as a PDGFR alpha or one of these fusions, or something that's not a KIT mutation. What's the role of the imatinib therapy in that point, or any other drugs?
Right, so this is where it gets tricky. So for PDGF alpha mutations that are likely to be sensitive to Gleevec, then it's pretty straightforward. For the resistance mutations, like the D842Vs, we now know that we've got drugs that are really active for patients with D842Vs, new drugs. But those trials are not being run yet for adjuvant therapy that I'm aware of. And so that's one of those questions where you've got to have that conversation and think about a little bit outside the box. In general, for somebody, even if they're high risk, that does not have a KIT mutation, I'm not pulling out matched targeted therapies unless there's pretty clear data that they are effective in that sort of targeted fashion. So let me explain that a little bit more. So I have a patient with a MEK mutation. MEK is a gene that is, this is the first case I'd ever seen where that was a mutation in a primary GIST model. But there's a drug that blocks MEK called Mekinist, right? But in other tumor types, just using Mekinist alone doesn't fix cancer. You have to have combinations. It's a very complicated pathway. And so even though intuitively, with a high-risk GIST, I would say, I'd love to put this guy on Mekinist. Mekinist has side effects, it's got risks, and there's no data to show that I'm really going to change his outcomes. So I tend to not whip those out early, but I really am careful about following them, and we make sure we've got trials lined up for them in the event that they do recur.
Going back to your statement about the risk stratification, Dr. Miettinen, is there anything on the horizon we should think about, or that's in the future of changing how we think about risk stratifying patients, or is there any new things out there?
Ideally, we should have specific risk stratification for each type of pathogenic groups of GIST, so KIT mutant specific, PDGFR alpha mutant specific, and so forth. And we know already that PDGFR alpha mutant GIST are on average less malignant than KIT mutant GIST. So sometimes the mutation analysis itself we are working on that right now, and almost 150 patients now, maybe even more if we can put some forces together from different institutions. And this group, as many of you know, are diseases that can be metastatic, but they are not progressive. So the liver metastasis doesn't mean the same thing in STHs as it means in kidney, because the disease may be still very indolent. Then technical development in stratification is that sometimes people wish that they can substitute mitosis counting by an immunohistochemical test such as phosphorylated histone, because the mitosis spots light up in this immunostain. It becomes very convenient to count mitosis. However, this is not tested very well, and actually it is not totally comparable with histologically observable mitosis. So if we convert to phosphohistone, count new numeric values for mitotic counts have to be produced.
Okay, thank you. I'll sort of open this up to all of you. So, a patient has evidence of a recurrence, or it has a new mass on their imaging. How do you know it's a GIST and not some other kind of cancer? What's the role of biopsy in this?
So that's a good question. I would tend to believe that your first thought, of course, is that it could be a metastatic gastrointestinal stromal tumor if the lesion is present in the usual sites of metastasis. Clinically, the disease doesn't tend to metastasize early to the lungs, and it has to be very advanced disease until you get unusual locations like lung and other sites. So if the disease is recurred, or there's a nodule present in a patient who's had gastrointestinal stromal tumor, and it's developed in the liver or in the peritoneal cavity, then of course the first thought is that this is probably metastatic gastrointestinal stromal tumor. I think a biopsy is warranted to confirm that suspicion. And of course there are some mutations at which, certainly if folks are in the setting of treatment, that can confer resistance to treatment, that might elucidate some thoughts as what to do next.
There are some tricky cases, for example, neurofibromatosis 1 patients often have small intestinal GIST, which most of the time are benign. But then they also have a tendency to develop neurofibromatosis tumors that can be benign and become malignant. And in some cases, there is a confusion about malignant peripheral nursing tumor, which is thought to be GIST metastasis from patient's intestinal tumor. And to sort them out is critical, because none of the GIST therapies are good for that type of malignancy.
Okay, thank you. But why don't we